Well, welcome everybody. Thank you so much for joining us for Measurement in Adolescent and Young Adult Oncology from Development to Implementation. And this is hosted by the Society for Health Psychology's Adolescent and Young Adult Interest Group and co-sponsored by the Society of Clinical Psychology, APA Division 12. I'm Carly Murphy. I'm the Measurement Chair of the Adolescent and Young Adult Interest Group. And before we begin, I just have a few items to share. So first, this and all Society for Health Psychology virtual presentations are offered as a free benefit of membership in the Society for Health Psychology. Please invite your colleagues and students to join to ensure that unlimited access to future presentations and other society benefits. You can visit our website at societyforhealthpsychology.org for more information. Second, this event is being recorded. Anyone who speaks during it, for example, to ask a question, is agreeing to be recorded and is granting permission for the recording to be posted on our website. This webinar is also eligible for one continuing education credit under the Society of Clinical Psychology Division 12 sponsorship. CE evaluation information will be sent via email to all who attend the full presentation shortly after the webinar. We'll leave the evaluation portal open for 1 week until 5 p.m. Eastern on Friday, February 23rd, 2024. CE certificates will be sent via email within 5 to 10 business days after the evaluation period closes, using the email at which you enrolled in this session. All participants are invited to submit feedback via the evaluation, even those not seeking credit. Questions will be taken at the end of the presentation, and you may submit them via the chat feature during the presentation. A moderator, myself, will call on you at the end to unmute and ask your questions. Before we move on to our panelists, I just wanted to give a quick overview of who AYAs are and our AYA interest group within the Society for Health Psychology. So in the context of oncology, AYAs are defined as individuals between the ages of 15 to 39 years old who have been diagnosed with cancer. And this is really a unique developmental time frame with a lot of rapid social development and emotional development. Oftentimes, these patients find themselves lost between pediatric and adult healthcare settings, especially if they have to transition at some point during their care from a pediatric setting to an adult setting. And also notably, this is a really common time broadly in which mental health concerns onset. So the Society for Health Psychology AYA interest group provides a structure for Society for Health Psychology members to have an active role in the advancement of research, practice, policy, social justice, and advocacy for AYAs with chronic health concerns, including cancer. And it's also focused on raising awareness of the unique developmental needs and challenges that are common in this population. That QR code will bring you to our website, and you can also feel free to contact our chair or chair-elect, Elise and Ziva. And now I'm honored to introduce our panelists. So our first speaker is Dr. Michael Hoyt. He's a clinical health psychologist and professor at the University of California, Irvine, in the Department of Population Health and Psychological Science. Dr. Hoyt leads the Behavioral Medicine Research Lab at UC Irvine, and his research is focused on the biobehavioral processes related to psychosocial adjustment and coping in the context of chronic disease, health-related adversity, and cancer survivorship. He is also the editor-in-chief of the International Journal of Behavioral Medicine, the president-elect of the International Society of Behavioral Medicine, and a fellow of the Society of Behavioral Medicine, and has been elected into the Academy of Behavioral Medicine Research. Our second speaker, Emily Haynes, is an assistant professor in the Department of Implementation Science at Wake Forest School of Medicine, and also the research director for the Adolescent and Young Adult Oncology program at the University of North Carolina. Her research is at the intersection of implementation science and cancer care delivery, with a focus on adolescent and young adult oncology. She's particularly interested in the development and implementation of interventions to coordinate multidisciplinary cancer care and holistically meet the needs of young people with cancer. Her work is funded by Teens Cancer America, the Be Loud Sophie Foundation, and the National Cancer Institute. Lauren Lux is a licensed clinical social worker who directs the AYA Oncology program at UNC. Her work as a program director focuses on patient care, psychosocial research, programming, provider education, quality improvement, and advocacy. Along with her fabulous partners in crime, she leads efforts to improve care for AYAs around the state of North Carolina and is involved in the advancement of the AYA oncology field in the United States. She has worked as a clinical social worker in the field of oncology throughout her career, and her clinical practice and program work is inspired and informed by the incredible young people she meets every day. So now I'm going to hand it over to Dr. Hoyt, who's going to start us off.
Great, thank you so much, Carly, for all the work you did to make this this webinar happen. So today I'm going to talk a bit about some of the work that I've done a long time ago on developing the cancer assessment for young adults, which is a measurement tool that was developed in young adults with testicular cancer as a tool to measure health-related quality of life. And I kind of chuckle a little bit, and that I'm talking about this because I even tried to initially decline this invitation because I don't think of myself as a developer of measures or a particular expert in this. And so what I'm hoping to offer you today is a bit of an example of what jumping into this from that perspective feels like, a little bit of a leap into the unknown, but also how it led to a whole program of research for me. And so hopefully that will inspire someone to also leap into the unknown a little bit. Slide. So this work, as I said, was developed in young adults with testicular cancer. And as many of you probably already know, testicular cancer is among the most prevalent cancers in this particular age group and can lead to a whole host of physical and psychological adverse impacts, particularly those receiving certain types of chemotherapy. Neuropathy, cognitive disturbance, fatigue, hearing loss are common impacts, high risk for cardiovascular disease, high risk for development of a second cancer across the lifespan. Certainly the psychosocial impact, as you can see, some of those things on this slide include higher prevalence of depression, anxiety, body image issues, masculine image interference, occupational problems are common. In some of my own data that I've done since this project, we find about a third of our samples meet clinical criteria for significant depression, and a lot of these things can be long-term and persistent. So all of this is to say that it was very clear, particularly at the time that this work began, that we needed to understand, measure, and eventually improve quality of life in this group. Slide. So we set off on a measurement development project, and this work and my sort of leap into this unknown work started with a Young Investigator Award from the Lance Armstrong Foundation, as it was called back then. And this was a call, as some of you may have participated in, for work to develop measures for the very reasons that I mentioned. Slide. So what was our plan? Where did we begin? We certainly started with an extensive literature review that indeed suggested a strong need for measures focused and adapted for, I'll say, YAs in this case. And then we did conversations, interviews with clinical providers and stakeholders, urologic surgeons, health psychologists, cancer care providers, to really generate a list of priority areas to explore, and then started a process of sort of in-depth, semi-structured patient interviews. And I'm going to show you a little bit of some of those interview quotes. Slide. So we did these interviews in California. In total, we did 21 in-depth, sometimes 3-hour interviews, really asking about how these guys thought about quality of life, what were the ways that they felt their quality of life had been impacted, somewhat starting from an open slate and then also sort of bringing in what we knew about health-related quality of life and sort of embarked on sort of a theory-driven thematic analysis, I'll say. And so initial themes were identified in the interviews, and this sort of led us to a conceptual model. But for the purposes of what we're talking about today, an initial pool of questionnaire items were developed. Slide. So I'll just share a few of these slides. I'll go a little bit quickly through these, but we certainly saw evidence for all different types of morbidity, evidence for the different factors, the psychological and physical factors that I shared a few slides back. But when you look at the quote on this slide, right, we start to see some of the elements of some of the maybe unique dimensions or the way that they talked about them in a YA framework. Certainly, there was a lot of focus on emotion and emotion regulation, and talk about sort of having an action orientation, sometimes in response to those emotions, as this quote sort of talks about, like, I had to get up, I had to get busy, I had to do something when I felt that way. Slide. We also saw pretty consistently across a lot of these interviews a focus on goals, goal clarifications, values clarification. How do you pursue goals? How do you pursue goals that have been challenged? How do you pursue goals that are perhaps now reflecting shifted priorities? And how do you sort of express and process the emotions that may sort of correspond to those kinds of goal challenges? And so we sort of started to come to this idea that this sort of skill-based way of thinking about goals may map onto a self-regulation framework. Slide. We certainly saw lots of evidence for different types of emotion regulation strategies, affect labeling, emotional and cognitive processing skills being truly important, not just to sort of coping with cancer, but really how they defined their quality of life and how cancer affected their quality of life over time. Slide. Right, this quote I just love because he just sort of lays out processes of emotional approach coping, right? He just talks about sort of sitting around and literally processing what's been happening, allowing himself to feel and express some of the emotions. And for a lot of the guys that we talked to, this was very novel, and this was not easy or comfortable in all situations for them to do. Slide. So, sort of what we come to here is some things that I like to highlight as that came up to the surface as particularly important and got baked into our measurement development. And that was certainly the emotion regulation piece, the goal-related pieces, but also this sort of active, action-oriented approach and paradigm of quality of life. Slide. And then this is the last quote I'm going to show. This is probably one of my favorite quotes, right? This person says, the end of chemotherapy or hearing you're cancer free was supposed to be the end of the story. And then goes on to say, this sort of was a moment where they had a rush of agency, something I sort of think of as almost complicated agency. How do you sort of pursue the options that seem so important and yet something seems so not important anymore in this sort of post-cancer moment? Slide. So what we came to here was a sort of set of quality of life domains that are reflected in the final measure that was developed. And I think some of them reflect the things that I've been sharing, this sort of skill-based domains, and also, of course, the more traditional functioning domains that we might expect to see in a health-related quality of life measure. Slide. So we had a couple more preliminary steps. Certainly we needed to generate items from all of this work. And initially we developed 113 different items. And we did a preliminary test group of 15 YA survivors doing sort of the cognitive interview step, talking about comprehension of the items, readability, overall use of the instrument, establishing at least an 8th grade reading level to the best of our ability, and sort of thought about how they would interact with the tool that we would be field testing. Slide. So then we did go into sort of the more nitty-gritty field testing steps of developing our measure. Slide. And I'm not going to go deep into the psychometric work that we did, just to sort of, this is a busy slide, but just to sort of show you, first, we sort of thought about the more traditional psychometric methods of acceptability thresholds, validity measures, reliability measures, and having sort of clear criteria for what we were going to consider acceptable. Slide. But I also had the advantage of bringing in a strong psychometric collaborator who was an expert in Roche measurement methods, which was totally new to me. That was not in graduate school, right? Learned a lot about Roche measurement and how it was connected to IRT. And as an aside, there's a whole debate in the quant psych world between IRT and Roche that you probably don't want to get into, but really learned about how we could use Roche measurement methods, which were really sort of focused on how the observed data sort of fit the model we were putting forward. And this gave us more sort of statistical ability to look at creating standalone subscales, to reduce the number of items based on how they performed, identify scales that also fit the data. And so it was a nice sort of balance between the work that we had done up to that point that was very theory-driven, patient-driven, and now adding in an element that was much more data-driven and was certainly interesting to learn about those things. Slide. We had a whole host of validation measures. These are just some of the main ones to sort of reflect some of the domains we were interested in. So we certainly had those in the data. Slide. So we administered our items along with validation measures to a sample of YA testicular cancer survivors. In this study, we used an 18 to 29-year-old age range. Slide. And we used the California Cancer Registry to do the recruitment for this work. And you can see, sort of how we landed on the time one sample of 171 respondents. This was about a 59% response rate of possible cases, which we were pretty happy with. That largely reflected the demographics of the state of California. And we had 113 of those participants repeat the questionnaire 1 month later, mostly for that sort of test-retest function. Slide. So you can see, I won't give you a full demographic table, but you can see, some demographics on the slide here. Slide. So again, I'm not going to go into the results of the scale property. It's all been published in the paper that we put out there, but I think, you can just see here, this is a table that was in the paper where we can sort of put those traditional psychometric results side by side with the Roche analysis and sort of consider those things together, which was really nice, and I thought an advantage to how we sort of established the properties of the Kaya. Slide. Here you can see the response scale that was guided very much by that Roche measurement ended up being a 0 to 2 scale, which was interesting and a little bit not what we had initially thought. These are some of the items you can see reflecting that balance between the sort of skill-based approach and the more functional approach. Slide. And again, the paper has the outcome, the means, the sort of data from the sample. Slide. Okay, and this last couple of quick slides here, I just want to sort of, land on this idea that this work sent me down a path that became a strong program of research that I continue to this day that included intervention development. Slide. From that initial validation sample, Carly, yeah, there you go. you can see we started looking at those goal processes and trying to create an understanding of how they might work overall. And so started to, from this, build a conceptual model slide that was, over time, over lots of time, created into an intervention that we called GAT, or goal-focused emotion regulation therapy slide, that we published some initial pilot trials. We're now doing a large clinical trial. So this really, this dive into measurement development really set me off on a course to study YAs, AYAs, something I hadn't been doing at the time, to get this sort of perspective on measurement development, and then to use that measurement development work to sort of think about pushing other areas forward, including intervention work. Slide. Thank you so much. And I think the last slide says thank you.
All right. Dr. Haynes, I will turn it over to you.
Great, thank you. Let's see here. Okay, can everyone see my slides?
Yep, you're good.
Okay, awesome. Well, hello, everyone. My name is Emily Haynes. As Carly mentioned, I'm an assistant professor in the Department of Implementation Science at Wake Forest School of Medicine. I'm also the research director in the AYA Cancer Program at the University of North Carolina. And I'll turn it over here to Lauren to introduce herself.
Hey, my name's Lauren Lux. I'm a clinical social worker and the director of our AYA program here at UNC in Chapel Hill.
Great. Well, we're super excited to talk to you about the AYA Needs Assessment and Service Bridge, or NASB. And I feel like it's important to kick this off by saying that NASB was developed as a tool to inform care delivery. It was not developed as a measure for research. So missing from this presentation is going to be kind of a mention of psychometrics. We have some future work related to that on the horizon, but for the purposes of this presentation, we are really focused on developing a tool that could help provide clinical care to our AYAs at UNC. So with that in mind, I thought it would be really helpful for Lauren to give us an overview of the AYA program at UNC so you can kind of understand the setting for which this tool was developed.
Thanks, Emily. So I will just tell you a little bit about who's on our team and what we do. So we serve patients here at the Cancer Hospital in Chapel Hill. We have about 450 newly diagnosed AYAs come through the door each year. Obviously, a lot of those people roll over into following years and sort of compound exponentially the number of patients that we try to serve. So our program operates across the sort of three-legged stool approach that you often see in academic medicine. So clinical care, research, and education. I guess maybe we could add a fourth leg to make the stool sturdier, and that's advocacy and outreach. And so our team is comprised of 11 folks. It's actually, we've grown since this photo. So we have clinicians, including a clinical social worker, full-time AYA clinical social worker, full-time AYA nurse practitioner, a full-time fertility preservation program director who is also a social worker. We've got an AYA palliative care doc. We have a research assistant that's embedded in our team to help us do this work. Medical oncology liaison, medical director, Emily, thankfully, and bringing on a project manager as well. So just a host of people sort of across that work across those three avenues to really try to improve care both at UNC and across the state of North Carolina and nationally. I think we're really interested in sharing what we learn and also learning from others in this space. It's a relatively new field, and I think all of us in some ways feel like we're building the plane as we fly it. So excited to connect with some folks on the call, and happily we'll share the things that we know and learn from you as well.
Great, thanks, Lauren. So just to orient you to where we're kind of going with this, I'm going to start by giving some background on why we set out upon this line of work. I'm going to really briefly talk about how we developed NASB before diving into some results from a feasibility pilot study. Lauren is going to talk about what has been going on since that pilot and get into a discussion of implementation challenges. And then we just want to share with you some broad reflections on this work of integrating needs assessments or other patient-reported outcome measures into routine cancer care. So in the US, around 90,000 AYAs ages 15 through 39 are diagnosed with cancer each year. And there's a large body of literature to show that AYAs have unmet physical, psychosocial, and practical needs. But despite the scope and complexity of their needs, AYAs often don't use services and resources that are available to them through their cancer care programs, even when they don't face any access barriers like costs, insurance status, or local service capacity. AYAs report a number of barriers to service or resource use. You can imagine, for example, the sheer volume of information that is given to them at diagnosis and how sifting through all of this to find information that's compatible with their own specific needs could be pretty daunting. So to address this type of barrier and connect AYAs to the services that they need, we developed the AYA Needs Assessment and Service Bridge, or NASB. And NASB includes a holistic needs assessment, but from the jump, we really wanted to think beyond just the needs assessment itself. And this is where I always share the story of my dad when he was undergoing cancer treatment, and he became really frustrated by the battery of assessments that he was asked to complete during his cancer appointments. And he became convinced that no one was actually looking at this information or doing anything with it. So he started to just check off all of the most catastrophic boxes on these questionnaires just to see what would happen. But nothing ever did. No one ever really followed up with him about it. So we really wanted to avoid this and design NASB with actionability in mind, which meant being really explicit about the referral pathways that are triggered by needs in the assessment. For that reason, when I talk about NASB as an intervention, I'm talking about both the needs assessment as well as the follow-up piece, those referral pathways that are triggered by the assessment. So we spent several years developing NASB through an extensive user-centered design process. The whole process was guided by our design team, which was comprised of researchers, lots of different types of providers, and patient representatives. So we started with an existing tool called the Cancer Needs Questionnaire Young People, or CNQIP, which we thought was pretty holistic, but very long and cumbersome for use in routine clinical care. We did some usability testing with AYAs and providers to refine the CNQIP to promote its usability. And when I say usability, I'm just talking about the ease with which something can be used in practice. One of the most important changes that we made to the CNQIP was grouping needs by service expected to address them. And this goes back to the actionability piece that I mentioned earlier. So we really wanted to create an intuitive link between needs and services. I think about intervention work in terms of the what and the how. And being an implementation scientist, I'm really hung up on the how piece. So we used ethnographic methods to map out workflows and figure out how exactly we might roll NASB out in the clinic. And throughout all of this, we are meeting with our design team to iteratively translate study data into ideas about NASB's content, its delivery, and its implementation. So long story short, we ended up with a 58-item needs assessment that is grouped into 10 domains. So in the figure on the left, you'll see a snippet of the assessment. And then in the figure on the right, you'll see an example of the NASB referral pathways from the UNC pilot. So in this figure, the domains of the needs assessment are listed on the left-hand side, and then the referral pathways triggered by each domain are listed in the right-hand side. And the idea is really that each institution would tailor this map of referral pathways based on whatever services and resources are available in their setting. So once we had our prototype, we did a little mini pilot, I call it, to assess the feasibility of NASB's implementation in UNC's AYA cancer program. So can we integrate this tool into the clinic workflow? AYAs ages 18 through 39 completed the needs assessment electronically during a routine clinical encounter. The AYA nurse practitioner or AYA social worker then reviewed the AYA's needs assessment with them, went ahead and addressed any needs that fell within their purview, and then initiated referral pathways for any remaining needs. And then finally, we sent AYAs a follow-up survey about a month later to get their feedback on NASB and whether or not their needs were met. So this is a lot in one slide, but I just want to point out a few things. So 26 AYAs participated in the pilot. And I first wanted to point out that in terms of cancer diagnosis, we did see a range, but leukemia was disproportionately represented. And we think that this likely reflects the increased feasibility of recruiting AYAs who were inpatient for cancer therapy versus patients who were either outpatient and thus harder to catch at the opportune time, or inpatient for unplanned admissions and thus potentially too sick to engage. You'll also see that many participants were newly diagnosed, and I think this just suggests that this may be a natural point at which to introduce the needs assessment. So on the needs assessment, participants reported between 0 and 43 unmet needs, with an average of 13 unmet needs. And remember, the assessment includes 58 items total. So this slide shows the 12 most commonly reported needs, many of which fell in that information domain. 21 participants completed the post-intervention survey. And in terms of our implementation outcomes, average ratings for NASB's feasibility, acceptability, and appropriateness all fell around 4.5 out of 5. And then 77% of participants reported that NASB helped to address their unmet needs. And I've included some quotes from AYAs. For example, one AYA said, "I felt like it was a safe way I could express my concerns or questions that I may be scared to ask in person." So I'm going to pass it off to Lauren here to talk about kind of what's been going on since that feasibility pilot.
Yeah, so I think we've had a lot of trial and error since the pilot. So one, I think, really interesting piece of this is the assumption that young people only want electronic things, and that's the only way that they'll engage with you. So when we finished the pilot, we actually throughout the pilot, we attempted to send NASB to patients via MyChart before their visit with us, or maybe in between visits. And it's probably not surprising to people on the call who work with young people, not a lot of success in even getting them to open the link that we sent, let alone fill it out. So we kind of called an audible, and we would take an iPad to them during the pilot and have them fill it out on the iPad. It takes about 5 minutes when we were with them. The way that we've tweaked that since the pilot is that we are now really and truly using this as a clinical tool. So we take a paper, just old school paper copy with us, and we have a patient fill it out in front of us. And then we quickly look at the results and we ask the patient what they want to talk about today. I think it's one thing to express a need, it's another to want to engage in a conversation about it in that moment. And so we use it as a conversation tool and a clinical tool, and it's been extremely helpful. We are working to build in our EMR NASB as a way that, to have it be able to pull into our chart, which would be fantastic. Just as a sort of funny note, a couple of weeks ago, Emily and I got an email from the UNC Epic folks. We use Epic here, and they said, "Hey, 2.5 years ago, you asked if we could build the NASB into a form for Epic, and your turn has come up in line. Would you like us to continue? Would you like us to do this?" And I laughed in my office out loud and said, "Sure." And I don't actually remember the full extent of the request. Could we meet again to talk about it? And things have changed since then. The tool has changed a little bit, but I think if you're interested in getting a build into your EMR, I would maybe start now and plan for a lengthy runway. I think that a tool like this is pretty specific to our patient population and it can be a little tricky to convince folks of making it a higher priority in terms of epic and builds into your EMR. So we're looking forward to having that. So again, as a clinical tool, we can pull it into the chart. I anticipate we're still going to need patients to fill it out in real time with us. I think that getting patients to do it beforehand would be really tricky. And it's been a pretty easy sell to folks when we're with them and we can introduce the tool in person, explain why we're using it, and that we want to give them this menu of options to use. It's a great example for patients, I think, of you don't know what you don't know. When we ask a patient if there's something that we can help them with, and we ask an open-ended question, which many of us as mental health professionals are taught to do and encouraged to do, a lot of people, especially in those first few months of treatment, don't know how to answer that question, and they don't understand the scope of services that we can provide or that we can connect them to as well. So I really like the tool, not only as an assessment, but as a menu for patients, as almost psychoeducation, that we can say, these are the ways that we can help. These are even the ways that many other young people are affected by their cancer treatment, and just really normalizing it in that sense. I think the other piece that you'll notice when Emily showed those referral pathways for UNC is that not every comprehensive cancer center, community cancer center is going to have an AYA program, and that is okay. I think we built NASB, and this is sort of the brilliance of Emily, with all providers in mind. This, you don't have to have sort of AYA training or a special sauce or a program to administer the tool and follow up on the needs. I think as long as there are strong referral pathways, it's actually really interesting. We're very fortunate to have a robust AYA program here. However, what we're doing now is partnering with our patient navigation program, and we're going to integrate NASB into their work, because the frequency with which they touch patients, the system that they have, lends itself to the use of this assessment tool in that work. So we're excited to partner with other people in our institution who are not AYA providers. And I would encourage you to think about who those people might be in your institution as well. I think one final note about this is just the use of other validated measures. We as an institution have a distress screening tool that we use. There are anxiety and depression tools that we use regularly. I think that these are not mutually exclusive. NASB can be used in conjunction with them. I think if you take anything away from how Emily described the design and build of NASB, it's really not meant to be in the same sort of category as those tools. So it's a nice complement and can be used together. So, is that you, Emily?
Yeah, no, you go ahead and talk about some of the implementation challenges we faced.
Yeah, so I think as with any needs assessment, and as Emily alluded to her dad's experience, to ask about needs and not be able to meet them is not okay, right? We don't want to ask if we can't actually help. So some of the issues that we had as a team, and actually some of the reasons that we're partnering with those outside of our team, is that even with many providers that are AYA focused, we still don't have the bandwidth to administer NASB to all AYAs or respond to all of their needs. So how do we actually get this in the hands of all AYAs at the right time, right? I think, their first visit is not the visit to administer it. But also then how do we follow up on that information and make sure that we're actually connecting them where they need to go? I think that every disease group that we work with, from pediatric oncology to each individual pod on our adult side, has different workflows, different systems, different providers, and different resources. And so having NASB integrated into each of those groups proved to be really challenging. We thought early on about, do we have the disease group NP or navigator implement NASB? But the challenge there was so great in terms of, there was not a way to copy paste that from sarcoma to leukemia to lymphoma. Everybody has their own systems and processes. So one of the ways that we're working around that is working with another sort of umbrella group, our patient navigation group, who cuts across all of those individual disease silos. And that's been a great way to problem solve around that. I think thirdly is just what we have here is this absence of structured fields in the EMR to record the documented needs. I'm hopeful, given the conversation we had a week ago, that is going to change. But in the meantime, it was sort of free text, our own interpretation of the tool. And that takes a lot of time as a clinician when you're already charting in many different locations. And then finally, I think just finding the right time to administer the assessment to AYAs. So I think like I said, we knew that first visit, that's not going to fly. People are on information overload. They don't know what they need yet. Maybe a month or so in would be ideal, but then when again? And I think we landed on sort of every 3 to 6 months. But one of the challenges there is, how do you know when it's been 3 to 6 months? And we would hope that our tools that we have at our disposal would be smart enough to help ping us and remind us of those things. But we haven't really found a great way to do that yet. And so how do we systematically ensure that we're reassessing, knowing that AYA needs change so frequently? They're at a time in life where developmentally there's a lot of change, and we want to be able to capture that and deliver what they need in the right place at the right time.
So in the interest of time, we're going to move on to just some broad reflections on implementing needs assessment into routine cancer care. And, we're really focusing on the how in these slides rather than the what, in recognition that now there are multiple AYA needs assessment tools that exist. When we started developing NASB, there really wasn't a lot out there. And I think since then, a couple of different groups have developed this type of multidimensional needs assessment. So something that I've come to realize is that there is not a universal magic bullet for administering needs assessments in routine care. The ideal approach in terms of who administers, when, where, and how depends on the setting. So really taking the time to map out clinic workflows prior to implementation can go a long way in terms of landing on an administration approach that is minimally disruptive to clinic workflows. And, taking a phased in approach to implementation, for example, starting with one disease group and then expanding outwards, can help you kind of smooth out the kinks as you go. As Lauren mentioned, we initially thought we were going to administer NASB via MyChart, but like she said, quickly abandoned that approach. We had a lot more luck catching patients in the clinic when they are a captive audience. But a big takeaway for me is that AYAs have really different communication preferences. So to the extent that we took a multi-pronged approach to administering NASB, using MyChart, using text, using in-person encounters, that really expanded our reach. The last thing I'll say here is, again, touching on what Lauren mentioned, is that we know that needs change, so reassessment is important. We did solicit feedback from AYAs about how often they would like to complete NASB, and most said every 3 or every 6 months. So that seems to be the sweet spot if, like Lauren said, we can figure out a way to systematize that. I'll pass it off to Lauren here for some takeaways on the follow-up piece. What happens after an AYA completes the needs assessment?
Yeah, I think what's key here, what Emily has mentioned, is just really making sure those referral pathways are ironed out. And this is especially important if your sort of non-AYA staff members are the ones who are administering NASB. The more information and education that we can give those folks, the better. I think that who owns that work and who's going to make sure they're responsible for it, as we say here, is incredibly important. It often needs to be a dedicated person, so they're familiar with the resources and understand the workflow. And then I think, as we were talking about, incorporating these fields into the EHR is not just important for streamlined follow-up and referrals, but for tracking and reporting. So I think for AYA programs especially, or even people who are just interested in improving AYA care at their institutions, being able to describe what we're doing to take care of these patients is incredibly beneficial. And the best way to do that in your EMR is to have reportable fields and not just sort of have free text. So thinking about how we can capture this information in a way that we can pull it and use it to advocate for our patient needs and expanded program opportunities is key.
So apologies if you just heard a huge crash in my background. A massive tree just fell down right outside my window. So that was a lot. In terms of next steps, We have a grant under review to look at NASB's impact on some patient outcomes like psychological distress, health-related quality of life. Just undergoing this process of systematic needs identification and then connection to resources actually improve experience and outcomes. We also, as Lauren alluded to, UNC is a comprehensive cancer center with robust AYA services and resources. And we really want to explore implementation in other settings. For example, we know that most of our AYAs receive care in the community. So how does NASB implementation look in community-based settings? The other thing that we've talked about is whether NASB could be used for risk stratification. Is there a threshold at which AYAs could be classified as high need, medium need, low need? We haven't kind of explored what the optimal risk categories would be or delved into this, but it's definitely something we've talked about. So with that, I just want to see if Lauren has any final thoughts about NASB or its implementation or anything else.
I think the only thing I'd share is that Emily, you've been so generous in wanting to share the tool with others. And if you're interested in using it, please reach out to Emily and talk about how to help you implement it in your own practice or in your institution.
Yes, please do reach out. My email address is on the slide, and happy to share the most recent iteration of the tool with you. Also happy, like Lauren said, to have a conversation about implementation in your own setting. So with that, I will attempt to stop sharing. There we go.
Wonderful. Thank you guys so much. That was amazing. I'd like to encourage our attendees to put any questions that you have into the chat. I don't see anything there yet, so I will go ahead and start off with a question for the group. So one thing I was curious about is, what advice do you have for someone who is thinking about developing a measure that is targeted for AYA oncology?
I mean, I would definitely, do your due diligence. Like, is it needed? There's a lot more work in this zone happening now than, as I mentioned, mine was, in response to a grant call, because there was very, very little, if any, at that time, and people really recognized that, and that's really changed. And so I would sort of ask yourself, why you're developing a measure, and sort of have those conversations first.
I would add, and maybe this is obvious, but engagement of patients and providers in the development of measures. I mean, there were so many key little insights that we learned through our kind of user-centered design process. One example I'm thinking of is we initially had the items worded as like, do you need help with XYZ? And some of our AYAs said, you really need to change the word need to want, because we might need help, but we might not want it from you. So really rewording it to, do you want help with this? Another example would be our response options. We initially had more of like a Likert type, like somewhat agree, mostly agree. And then based on feedback from providers who said, if this tool is supposed to be used to identify services, then it's really just two options, like, do they want help or do they not want help? So we really collapsed our response options into kind of a yes, no, not applicable based on that feedback. So I would just say, yeah, engaging your stakeholders.
Yeah, and the other thought I'm having is the landscape has also changed on where you're going to administer it and how. And I think Emily and Lauren did a beautiful job of hinting at the major challenges you face when you're trying to integrate them into an Epic system or electronic format to systematize data collection, right? And if that's the goal, right, those are incredibly large conversations and long roads, as people have been talking about, that meet barriers that across the field, even outside of AYA, we haven't solved yet.
Thank you guys for that. That was really helpful. So we have a question from Janelle who asks, how did you stage rollout of assessment and link to interventions? Did you begin with any specific clinics or physicians with interest or buy-in? I think that's still directed towards Emily and Lauren. Correct me if I'm wrong. Okay.
You want to take a stab at that, Lauren?
Sure, yeah. I mean, I think for us, we're in the unique position of having an established AYA program that had started building those relationships with individual disease group providers many years before we brought this change. And so it was a lot easier to, I think, get buy-in. I think we can kind of answer the second question too, which was how did the providers respond to the work in developing the measures and sort of pros and cons in our relationships with them. One thing that they really loved was a summary of the needs. So what our nurse practitioner and our team did, and I acknowledge that this comes with a lot of time and energy and resources, was send an email to the oncology team with a bit of a summary of the needs assessments that popped up. The providers were incredibly grateful for that information, especially because, as you saw with Emily's sort of top needs, a lot of it, and this is, I think, especially related to the timing of giving the NASB sort of in that first month or two on treatment, was information needs. People wanted more information from their team, and their team had no idea, right? And we're bad at this as medical providers generally. We give information, we think we give it enough times, and we give it well, and patients, if you quiz them, would have no idea what we had told them. So that was really helpful. We got a lot of great feedback from the teams as it related to the sharing of that information so that they could provide better care for the patient.
Thanks, Lauren. That was really helpful. I think you guys kind of already addressed that second question. So I'm going to go on to the third one from Gary. Do you know if anyone has looked at the neurocognitive aspects of the cancer condition or its treatment? Is brain health or cognition a factor that's appreciated in this space?
Lauren can probably speak better to this. The answer is yes. I think that, but not in my research. So I wouldn't be the best one to speak to that.
Yeah, there's definitely a lot of work that's been done, both as it relates to the cancer and its treatment, more so in the survivorship realm. So I guess the two ways that I would think about it, that is both sort of chemo brain and brain fog during treatment and how long that lasts post-treatment, and then also like true cognitive changes from the treatment itself. And but that hasn't been specific to AYAs. I mean, I think there's a lot of childhood cancer survivor research around that, and there's starting to be more focus on AYAs as a subgroup of that.
Yeah, the name that's coming to mind for me with that is Danielle Tomatich. I believe she's at University of South Florida now. She recently changed institutions, but she is doing she has a K99R00 award focused on cognition and cognitive concerns in AYAs. Great. Any other questions from the audience? Feel free to pop in the chat. We've still got about 5 minutes left. One thing I was curious about, both Michael, in your development work, you used a number of measures, and then Emily and Lauren, you mentioned that in addition to the NASB, you're also administering other patient-reported outcome measures in the clinical setting. So I'm curious, how do you go about choosing a measure to use with AYAs?
Carly, are you talking specifically about kind of validation type measures in the development steps? Oh, wait, you're muted.
Sorry, open-ended. Really, if like wherever you think would be most helpful to talk about. Yeah.
Yeah. Well, I'll just say that at the, in the beginning of the work, when I started that project, there wasn't really either a testicular cancer specific sort of module or, in sort of the more well-known, health-related quality of life measures or a YA measure. However, halfway through our project, the European team was developing a testicular cancer module to the EORTC, I think it is. And we got permission to use, they were much further along. It wasn't YA specific, but we got permission from them to use it in our validation study. And, since then they've used ours to validate, so there's this little bit of an incestuous thing going on between the two measures. But, I think looking for, those that have, sort of been validated in the populations of interest, obviously is a starting place.
I would just mention too, in a clinical setting, a lot of the time it's kind of higher forces that are determining that. It's at the institution level, what kind of measure is being prioritized or kind of coming down the pike. And there's a lot of kind of political forces at play that a given clinic might not have much say over what measure is implemented.
Yeah, that makes a lot of sense. Janelle asked again, has there been any collaboration or cross-validation of either tool with the Promise AYA work of Dr. Salzman? And in full disclosure, Dr. Salzman is one of my mentors, and I believe one of Emily's mentors, and a close collaborator of Lauren's. So at least on our side, I would guess yes. But yeah, I'm curious if that work is in talks or in progress.
Emily, you want to answer from your perspective?
John, as my mentor, has been really involved in a lot of this work for years now. We don't have any formalized work kind of looking at NASB versus Promise AYA. They sort of serve very different purposes, but maybe Michael can speak to any kind of collaboration between his team and John.
We haven't, and I'm there's obviously a lot of good reasons to use Promise measures, and so I think that John's contribution in that regard is really, really strong, and definitely a tool that's useful to the field. I haven't really done much revalidation work with our measure, but yeah, if John wants to give me a call, happy to work with him on it.
Great. Well, on that note, I will close us out. So thank you all once again for attending the webinar today. Remember, if you would like CE credit for attending the event, to please respond promptly to the evaluation link that'll be sent via email shortly. And we'll leave the evaluation open until Friday, February 23rd, 2024. CE certificates will be sent via email within 5 to 10 business days of the closing of the evaluation period. And remember, you're encouraged to submit an evaluation, even if you're not seeking credit. The other thing I did want to mention is that we will also be sending out a resource of AYA-specific measures and some systematic reviews of the AYA measures used. So you'll have that on hand, and that will also be posted with the recording of this. So thank you all again. Wonderful to see everyone, and have a good afternoon.